Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
Welcome to another episode of Life in Sirens podcast. Today, it's just me, Sophie, because unfortunately, we've been a little busy. And by little, I mean, man, I haven't been this busy in a long time. So it's been a little difficult to get all three of us in a room together to record a podcast episode. Primarily, one of those reasons being this week we are giving the keynote presentation at the Alabama EMS conference in Orange Beach, Alabama, so stay tuned for some behind the scenes looks on that.
Hey guys, I promise Soph did not lie to you. She is on her own for today's episode. I'm coming at you from editing, but we wanted to take a moment. We thought it was really important to talk about Vanderbilt Life Flight. They lost an aircraft. Life Flight 1 went down relatively close to base. One crew member lost his life, and there are still two in critical condition. And we thought it was really important to take a minute to honor them. We all know how tight-knit a community EMS is. We all know each other in one way or another. To lose one provider is devastating, and to have two more lives hanging in the balance is unimaginable. When it's air, it seems to be that much more devastating. You know, they are our little angels in the sky, and they pop down when shit's hitting the fan, and they bring fun toys and expertise and blood, and they bring a sense of calm in moments of chaos. And we've all seen their faces come in the back of the unit and just been like, whew, thank God you guys are here. And to have a crew go down in that aircraft that they were going to come to you in is devastating. And so we wanted to take a minute to let everybody know that Middle Tennessee is going to be going through it, Vanderbilt Life Flight especially. We'll keep you guys in the loop if there's anything that needs to be done for Vanderbilt and for these families involved. We just wanted to take a minute to remind everybody to love each other and love each other well, to be grateful for those that show up, and to be thankful that, you know, we get to go to work and do it another day. So with that, we're going to take a minute, and then Soph is going to jump into this episode.
But since it's just me today, I figured we would talk about something a little straightforward maybe, which is pressors and antihypertensives. So let's start with low blood pressure. So when your patient's tanking, you've got three main suspects: the tank, so volume loss or dehydration; the pump, the heart's failing; or the pipes, they're just too wide open. Our pressors are there to either squeeze the pipes tighter, make the pump beat stronger, or some combination of the two. Now let's meet our main players. First up is norepi, the reliable one. If pressors were a team, norepinephrine would be the paramedic who shows up early, labels their syringes, and does everything by the book. It works mostly on alpha receptors, so it tightens blood vessels, and a bit on beta receptors, so it helps the heart pump stronger. That combo makes it the first-line pressor for most kinds of shock, especially septic shock. A study from 2022 with the BMC infectious diseases found that starting norepi early in septic patients improved their 30-day survival. I just love norepi. She's the one, alright? Next up, epinephrine, the one you're going to find on every ambulance. The adrenaline junkie, literally. So, epi's that friend you call when things are bad. like bad. It works on everything. Alpha, beta 1, beta 2. It'll raise your BP, increase your heart rate, and even open your airways. And like we said before, probably make the monitor yell at you because your patient's now tachycardic. We love it for cardiac arrest, anaphylaxis, and sometimes post-ROSC. It is a powerful one, but it's a little chaotic. It's great for emergencies, just not ideal for steady maintenance. Next up, dopamine. We'll call dopamine the washed-up veteran. Once a star, now semi-retired, used to be the go-to pressor, but studies showed higher rates of arrhythmias and worse outcomes compared to norepi. You'll see it in some protocols. It's really going away though. Its glory days are definitely gone, especially pre-hospital. Next up, we have dobutamine, and we'll call dobutamine the gym bro. Dobutamine doesn't care about the pipes, it is all about the pump. It's an inotrope, not a classic pressor, so it increases contractility without much vasoconstriction. So it's perfect when your patient's pressure is low because the heart's just tired. Think cardiogenic shock or maybe post-STEMI. But just keep in mind that it can make your patient tachycardic. Next up, we have vasopressin, the quiet supporter. This one doesn't hit the adrenergic system at all. It's actually an antidiuretic hormone analog that helps the body naturally hold on to fluid and constrict vessels. We don't usually start it alone in EMS, if ever, but in ICUs or maybe even some flight settings, it's used and added to norepi to lower the total dose needed. Now, here's the golden rule. Don't reach for a pressor until you fill the tank. If the patient's dry, all you're doing is squeezing empty pipes. Looks good on the monitor, but perfusion, it's still trash. So fix the cause. Give fluids unless contraindicated, and then start your pressor. If you're in a service that doesn't carry norepi, epi can still help, but titrate it carefully. It's a sensitive one, and always reassess, of course. And no matter what you use, document the before and after. I think sometimes we forget to document the results, so I just wanted to throw it in there. Next, let's talk about when the pressure is too high. Okay, let's flip the script. Sometimes our patient's not crashing low, they're sky high. That's where the antihypertensive crew walks in. High BP on scene can mean anything. Literally anything, from stress to pain to genuine hypertensive emergencies, and that's the key word, emergency. If there's no sign of things like organ damage, no neurodeficits, no chest pain, no shortness of breath, you don't really need to bring the blood pressure down in a way that maybe we would consider emergent. But when that pressure is paired with something scary, like pain that resembles something like a AAA, or stroke symptoms, pulmonary edema, that's when the second team steps in. So let's talk about our antihypertensive players. First up, we have nitroglycerin, the smooth talker, our most common one. It relaxes and widens blood vessels, reduces preload and afterload, and helps with chest pain and things like pulmonary edema. If your patient's BP is sky high, and they're in respiratory distress, maybe they have crackles, nitro, it's your first dance partner. Moving on to labetalol, this is probably the next most common one you're going to see on the ambulance. We'll call her the balancer. This beta blocker with some alpha action gently lowers heart rate and blood pressure. It's especially useful in stroke or pregnancy-related hypertension. The beauty of labetalol? It doesn't drop BP too fast. It's pretty smooth and controlled and predictable when we use it correctly. Next, hydralazine, the wild card. It's an older med, still used for a lot of things, such as pregnancy-related hypertension or when beta blockers aren't ideal. It's a direct vasodilator, so it works pretty quickly. So titrate carefully if you ever see it in transport. Next is nitroprusside. This is kind of like our ICU diva, if you will. Very effective and very dangerous if it's misused. It drops BP fast and requires close titration and monitoring. So it's rarely used pre-hospital unless maybe you're in critical care. But think aortic dissection or malignant hypertension with end organ damage. This is like serious stuff right here. Heavy hitter. All right. And here's the key idea for all of them. When you're treating high blood pressure, the goal isn't to quote-unquote normalize it immediately. It's to bring it down slowly and safely. Guidelines say usually drop 10 to 20% of the MAP in the first hour, but not faster. If you go too far, you can cut off cerebral or coronary perfusion and cause more damage than the high blood pressure was going to alone. Sometimes, honestly, your best medicine is reassurance and a quick ride to the hospital, but again, this is just a matter of deciding whether this is an emergency or not, which I know you're all very good at. So how do you decide what to do with the number you're staring at on the monitor? Let's ask ourselves these 3 questions. Number 1, do I know why the blood pressure changed? Is it the tank, the pump, or the pipes? Number 2, can I safely intervene here? Do I have the appropriate monitoring, meds, time, hands, etc.? Number 3, will this fix the cause or just the number? If it's septic shock and you've given fluids, try norepi. If it's trauma and they're bleeding, fix the bleeding first. And probably find a way to get your patient blood. If it's heart failure with flash pulmonary edema, nitro. If it's stroke, maybe labetalol, or rapid transport. You're not chasing numbers, you're chasing perfusion. So keep that in mind. Now let's talk about common pitfalls and pro tips. Let's talk about things we've all seen or done once and, well, never again. Pitfall 1, starting a pressor before checking volume. You'll squeeze that empty tank, raise the BP on paper, and still have a dying patient. Pitfall number 2, treating high blood pressure like it's a bomb that's about to go off. Don't drop a blood pressure 80 points in 5 minutes. The brain and kidneys will literally hate that. This is just a matter, again, of knowing emergent from non-emergent. Pitfall 3, forgetting your monitoring. And I don't mean forgetting to place the patient on the monitor. You've most definitely done that. I just mean if you're running a drip, you need eyes on that cuff every few minutes, making sure it's in the correct place, making sure that we are regularly cycling a blood pressure, so more than every 10 minutes, which most monitors are auto set to, and then also good documentation. And of course, we can call for help if we need it. Don't forget you have medical control at your disposal. Pitfall 4, overcomplicating it. I think sometimes we just do this when we're nervous. If you're not sure, stabilize, oxygenate, and like we said before, call for help. Pressors and antihypertensives are tools. They're not proof of being an advanced clinician, alright? So use your tools wisely and responsibly. Next, moving on to my favorite part of the show, trivia time. You know, we love a little friendly competition here on Life in Sirens, so let's do pressors versus pressure trivia round. Question 1. What's the target map you're usually shooting for when giving a pressor? About 65. Question 2. Which pressor is considered first line for septic shock? Norepinephrine or Levophed. Number 3. True or false? It's okay to use pressors before fluids in trauma. False. Fix volume and bleeding first. Question number 4. In hypertensive emergencies, how fast should you lower blood pressure? 10 to 20% of MAP in the first hour. Question number 5. Our bonus question. What's the real first-line pressor for every EMS provider? Personally, not for the patient. The answer is caffeine. Preferably energy drinks. But be careful, because those can literally raise your blood pressure. Alright, let's wrap things up. Pressors. They squeeze the pipes, boost the pump, but only after you've checked the tank. Norepi or Levofed is your steady workhorse. Epi is your chaos buddy. Dopamine is basically retired. Antihypertensives use when there's organ damage, the scary things happening, not just big numbers. Nitro for things like chest pain and pulmonary edema. Labetalol for smooth control, but watch your heart rate. And never forget, numbers mean nothing without context. Look at your patient, not just the monitor. If this episode helped you brush up, share it with your crew, your class, or your partner next shift. And if you want exclusives, you can head to our website where we will have all kinds of content, including a handout that is associated with this episode. I know this one was short and sweet. We'll get back on track next week for some longer form episodes. But as always, thank you for listening to Life in Sirens. And remember, numbers mean nothing without context. Catch you later.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.